Prenatal infections are infections that happen to mom while she's pregnant that can mess up baby. You're going to see these again in the pediatric lectures and their impact on baby more than their impact on mom. At the end of this lecture, what you need to be able to do is recognize how you prevent these diseases in mom, how these diseases will present in mom, and then how to treat them. There's no overarching theme other than these are the infections that can happen in mom that screw up baby. So there's going to be a lot of different details for each different disease. Let's start with group B strep. Group B strep is caused by a benign colonization of the vagina. That is, it's not normal flora, but mom can have it without any problem whatsoever. And it is the exposure to baby during delivery where it becomes pathologic. So mom is not going to know that she has it. We have to go looking for it. So it is going to be an asymptomatic screen. And in fact, we do this every patient, every time, because group B strep is going to be catastrophic to baby. So either we do an asymptomatic screen that shows positivity between week 35 and 38, or if you forgot to screen and mom has an infection, baby is going to present with a normal delivery. It's going to do really well in the first couple of hours, and then all of a sudden crash within 12 hours. Because what happened was that a normal, healthy baby was delivered through the group B strep, and now they've got group B strep sepsis, which is why we should screen every patient every time. The screening is a culture of the vagina at 35 to 38 weeks. And what we do to treat is we give mom penicillin. And if baby comes out and mom was positive, we can prophylax baby with ampicillin. So in addition to any culture positivity, what we do is give penicillin in a number of settings. And essentially what this means is that since penicillin is such a benign treatment, and the consequences of not treating is so devastating, you should look for a reason not to give penicillin. So you give penicillin in almost every instance where there could have been group B strep. That is any asymptomatic bacteriuria, or any bacteriuria at all. Anytime mom has ever been group B strep positive. If there was prolonged rupture of membranes, so that it has an increased risk of GBS positivity, and any third trimester culture positive for GBS. That means if you get mom in your labor and delivery room and she had a culture positive for GBS ever before, even if she's negative now, give her penicillin. It doesn't hurt mom, but it sure does hurt baby to miss group B strep. That is group B strep. Let's now move on to the next disease, hepatitis B. Hep B is a virus. It is a virus that is usually transmitted vertically. And the idea is that hepatitis B can be both acute and chronic. But in the case of OBGYN, you have to have a mom that's a chronic carrier. And during the birthing process, mom is going to infect baby. And because baby does not have a developed immune system, baby will then become a chronic carrier. There is no acute hepatitis picture in these patients. They just happen to get the virus in their blood. So the patients are going to be chronic carriers. And mom may be asymptomatic because she's still young enough where that chronic inflammation of her liver has not led to any sequelae. So in order to diagnose them, you have to screen them. And this is not an acute Hep panel. You're not looking for IgM with the liver enzymes that are exploding. What you're looking for is the chronic carrier state. So what you're going to do is get a Hep B panel. What you're looking for is the surface antibody, which shows that the person has been exposed and may be immune. What you care about more is the surface antigen, the core antigen. Surface and core antigen means that she is infected. There is the antigen floating around. And the E antigen, which means that she is infectious. There's much more details about this in the GI section for viral hepatitis, because there's different ways of showing if she's been immunized or got exposed and is immune. But what you care about in the OB patient is, does she have antigen? Is she shedding virus? Can she give it to baby? The exposure to baby generally occurs in the birthing canal, so you avoid that exposure with C-section. But that's not good enough. You want to make sure baby has no virus in it as it's born. So what you're going to do is give baby IVIG as soon as it's born, as well as the Hep B vaccine. This is sooner than you would give this vaccine in most children. What you're doing is binding up all the virus that could have gotten into baby and priming baby's immune system to kill it. So do a C-section and IVIG Hep B and Hep B vaccine upon delivery in any mom who you think is a chronic Hep B carrier. This will avoid baby becoming a Hep B carrier as well. Another virus we care a lot about is HIV. Unlike Hep B, HIV is a virus, but this one can cross transplacentally. And there's exposure to blood and mucus during birth. So baby can get infected just by being inside mom or by coming out through mom. So the way you suspect HIV in mom is with an asymptomatic screen. You're going to screen these patients every time they get pregnant. But the way you should suspect mom has HIV is if she has opportunistic infections, or has other evidence of a decreased immune system. Because HIV is going to steal her immune system. There's an entire infectious disease lecture dedicated to HIV in the medicine lectures. The way you diagnose someone with HIV is to do an ELISA first. This is a rapid and sensitive test. You confirm with a Western blot. Once the diagnosis is certain, what you want to do is figure out where mom is at in regards to her disease. You have to get a viral load. The higher the viral load, the more likely she is to shed virus into baby, and a CD4 count. The CD4 count tells you what mom is at risk for getting infected with. If you have a CD4 count of 200, you have AIDS. The treatment, then, is first, of course, to find the HIV before she gets pregnant. And you treat mom the same way you treat anyone else. You use HAART, which is 2+1. 2 nucleotide reverse transcriptase inhibitors and 1 of anything else, either a non-nucleoside reverse transcriptase inhibitor or a protease inhibitor. This is the way you control the viral load. In a very low viral load or undetectable level makes baby not at risk transplacentally. But if you find mom to be infected with HIV and it's towards the end of her pregnancy, you can give AZT to reduce transmission. This is someone with a raging viral load who you at least want to try to reduce the transmission to baby as best you can. Give her AZT. And because in the birthing process you have exposure to blood and mucus, usually perform a C-section. There's a lot more detail in that infectious disease lecture, but what you need to know is HAART as soon as you can, AZT to reduce transmission, and C-section delivery. The next virus we're going to talk about is herpes. You're going to see a lot of parallels between herpes and zoster. The path is that it's a virus that hides in the dorsal root ganglion, and that a primary viremia affects baby in utero, and a secondary reactivation only causes lesions on the skin that if baby never touches aren't an issue. The idea is that the virus is in the dorsal root ganglion. Once it's there, all it does is travel up and down the nerve to the skin. On a primary infection, you'll have the primary viremia. So that if mom has had herpes previously, her only risk to baby is reactivation. You'll be able to diagnose mom with herpes because she'll have painful ulcerations or vesicles on an erythematous base. If you look in the infectious disease under genital ulcers, you'll find more details about herpes. The diagnosis is usually pretty clear. If you see a painful vesicle on an erythematous base, you're done. But you may have a bunch of unroofed vesicles that become one confluent ulcer. It may look like another disease that can happen to the genitals. So if you're concerned, get a Zank prep. And a Zank prep will show you perinuclear inclusions and nuclear molding. That's the diagnosis of herpes. Now, the problem is that if she has a primary viremia, baby's screwed. Nothing you can do about it. That hits baby hard. But the secondary reactivation is only on the skin, generally on the genitals. So if baby never touches that lesion, baby doesn't get herpes. So the secondary reactivation is treated with C-section. And of course, you can control those lesions with acyclovir. So now that was herpes. Painless vesicles on an erythematous base, treat with acyclovir to control them. And if it's the primary viremia, there's nothing you can do. So counsel mom for safe sex practices. The other virus that's very similar to herpes is zoster. This is the virus of chickenpox. It is a virus that hides in the dorsal root ganglion. Primary viremia gets into the blood and can affect baby. Secondary reactivation is on the skin. And so unless baby touches it, no problems for baby. This sounds a lot like herpes because they're in the same family. You'll be able to spot someone who has a primary zoster infection because they'll have chickenpox. And if they're actively having chickenpox, they are currently in the primary viremic state. If this happens to mom while she's pregnant, baby's screwed, nothing you can do about it. But reactivation is shingles. And unless baby touches the shingles, not really a problem for spread. The diagnosis is clinical and there's no real test you can do. What you should do is vaccinate mom. Now it's recommended that every child receive the Zostavax shot to prevent them from getting chickenpox. And if mom had never had chickenpox before and not received the vaccine, she should be vaccinated before pregnancy. Giving the vaccine during pregnancy exposes baby to the primary viremia. Don't do that. If you're going to vaccinate, make sure it's before pregnancy. If she's having shingles, it's not really a problem for baby, but you can give her acyclovir to reduce shingles, to take away the duration and limit the pain. But here should be your primary takeaway from zoster. If mom has never had chickenpox and never got vaccinated and is now pregnant, she needs to be isolated from all children who could have chickenpox. That means she may have to be isolated from her own children if they do not have chickenpox or have not been vaccinated as of yet. This is going to be a great test question because that's such an extreme measure to take, but it's the right one to do. You should isolate from her own children if they've got chickenpox or are going to receive the vaccine and she hasn't. And if she does get exposed, give her varicella IVIG. Try to bind up all the virus before it gets to baby. What will happen if you don't prevent the primary viremia is baby's going to have zigzag skin lesions and be small. And have small eyes and small extremities. So recognize how the similarities of zoster and herpes. The goal is to prevent that primary viremia. We have a vaccine for zoster, we don't for herpes. And secondary reactivation is all about keeping baby away from the skin lesions, because the only way baby can get infected if mom had already had the virus is by touching the skin lesions. Okay, we're going to move on to syphilis next. Syphilis is also talked about in the infectious disease lectures under genital ulcers. It's a spirochete, and it's an STD. The patient will present in one of three ways depending on the stage. Primary syphilis is the painless chancre. The spirochete hasn't gotten into the blood yet, and the body has not had a chance to develop an immune response. Secondary syphilis is the targetoid lesions on the palms and soles. It can also be everywhere else in the body. These lesions are infectious. Tertiary syphilis is any neurologic symptom in someone who has positivity for signs of having had syphilis. The diagnosis is different based on each of the stages as well. I'm rushing through this because you can watch a lecture strictly on syphilis and infectious disease. The primary lesion is diagnosed by dark field microscopy. The secondary lesion is going to be diagnosed first with an RPR, demonstrating that they had been infected with syphilis previously, and then titers of the treponema antibodies. And tertiary syphilis is diagnosed with a lumbar puncture. The treatment for anybody with syphilis is penicillin. If you're penicillin allergic, you can get doxy or any tetracycline. The problem is that pregnant females cannot get tetracyclines because it ruins babies' bones and stains their teeth. So if you are pregnant and allergic, this is also a great board question, you give them penicillin. And people normally recoil from that because, but wait, they're penicillin allergic, why am I going to give them penicillin? You give a penicillin desensitization. Penicillin treats syphilis, and it's the only treatment of choice for anyone who is not allergic or is pregnant and allergic. If you don't treat the syphilis, there's two possible presentations that baby could have. If mom got infected with syphilis, that syphilis got into her blood in the first trimester, baby is dead and macerated. This is early congenital syphilis. If she gets infected towards the end, in the third trimester, you're going to have and I have to write out all of these because I want you to know them, because this is what they're going to see in the test question. The saddle nose, the saber shins, the Hutchinson teeth. And I recommend you go take a look at these because they'll show you a picture of a baby with Hutchinson teeth and then ask you, what was mom infected with? So syphilis is an STD that has multiple presentations, and all you need to do is give her some penicillin and she's all set. Recognize that how much penicillin and how you give it is going to vary based on the stage, and I'm not going to cover that information in this lecture. 2 more to go. Let's talk about toxo. Toxoplasmosis is a parasite. It's a parasite that's found in cat litter. Mom doesn't feel anything. She might have a mono-like syndrome if this is her first time being exposed. But chances are most people have had exposure to toxoplasmosis in the past and they've cleared it. So likely it's going to be asymptomatic and we simply screen. Every patient, every time, gets a toxo antibody. If they are toxo positive, it means that they have had exposure to toxo and have cleared it. This is why we get the toxo antibody early on in pregnancy. If they're toxo negative, then they can become infected. We have no treatment for the primary infection. So the treatment for mom who is antibody negative is to avoid exposure. So you avoid cats and cat litter. If she is already antibody positive before getting pregnant, there's no risk to baby. Because if mom comes in contact with toxo, she's just going to destroy it. So the only time baby is at risk for toxoplasmosis is in a mom who is antibody negative who then encounters toxo, causing that primary infection that leads baby to have chorioretinitis, brain calcifications, and symmetric intrauterine growth retardation. The last one we're going to talk about is rubella. And you very rarely see rubella because measles, mumps, and rubella is a vaccine you get very early on in childhood. In fact, they'll have to tell you in the clinical vignette that this person refused their vaccines early on in childhood, or their parents wouldn't let them get them, or they're from a foreign country. They won't give you a rubella patient without explicitly saying that this person didn't get their vaccines. It's a virus. It's essentially the measles virus. The patient is going to present with measles. The diagnosis is clinical. The treatment is that you should have vaccinated, but you must vaccinate 3 months before pregnancy starts. The reason is this is a live virus, and if you vaccinate mom while she's pregnant, you expose baby to the virus, causing the rubella syndrome. That syndrome is deafness, cataracts, and congenital heart disease. Lowest yield on the list, rubella, but if they do give you a history of refusal of vaccines or being from a foreign country, this one should jump to the top of your mind. Okay, so what we covered in this lecture was a bunch of different infectious diseases that can infect mom that might affect baby. What you need to realize is that most of these diseases can be prevented with vaccinations or treated with antibiotics. There's a lot of little nuances, and what you need to be able to do is pick out the features of the primary infection in order to diagnose the disease, and then know the little nuances about each treatment. For example, the big one being hiding mom from her own children if she's never had chickenpox. That is prenatal infections. We make these videos for free, and we need your help. Please donate, because without your donations, we can't make any more videos. Please donate.